So welcome back everyone, and thank you for joining us today as we continue our journey to cover the 5 steps of evidence-based practice. And today marks the end of our journey together as we're going to cover step 5, where we're going to review the 5 A's and identify ways that you can implement these skills into your everyday clinical practice. I'm Dr. Zoe Michaeliff, and I'm the Research Operations Manager at Northern New South Wales Local Health District, and I belong to one of the member organisations of the Rural Research Collaborative Learning Network, otherwise known as RR-CLaN. And today I'm joined by Associate Professor Chris Williams, and Chris is a conjoint academic holding the position of Research Development Manager at Mid-North Coast Local Health District, and is also a Principal Research Fellow with the University Centre for Rural Health at the University of Sydney. So before we begin, I would just like to acknowledge the traditional custodians of the lands and waters where we live and work. We acknowledge the traditional custodians' living culture, their connection to country, and their contribution to life of this region. We pay our respects to the ancestors and elders of the region and to all Aboriginal people past, present and future, and any Aboriginal people who will be joining us today or viewing the recordings at a later date. Welcome. So as I mentioned, we're nearing the end of our time together through the evidence-based practice series, and we've gone from identifying why evidence-based practice is important and asking an important and answerable research question, acquiring the evidence, appraising the evidence to determine its believability and usefulness. And last week, Dr. Alex Stevens led us through how to interpret the findings of a randomised controlled trial in terms of interpreting both the statistical and clinical significance of the findings. And I'll briefly run through these key learning points of this session in the next few slides. So if you haven't already had that aha moment, interpreting the findings of research, particularly randomised controlled trials, can be quite daunting. But once you realise there are actually only 2 ways to interpret study findings of treatment effectiveness, it all becomes much clearer. So how you interpret findings begins with an understanding of the type of data the authors have used and collected. And if this data is quantitative data, so in terms of these are numbers, either whole numbers as discrete data or continuous numbers, such as maybe a pain scale, you calculate the difference between the 2 treatment groups, so calculate the difference between the average or the mean between those 2 study groups. And then you interpret the findings around the point of no difference, which in this case is 0. For qualitative data, and personally I find it a lot easier to think about this data as categorical data. So we're thinking about variables such as sex or hair colour, or if there's order to the data, these are ordinal data. So it could be like the highest level of education attained. If the authors are comparing the outcomes between 2 treatment groups, this is done as a ratio. So the relative level of the outcome in one study group compared to the outcome in the reference group. And you interpret these findings around a point of no difference being 1. And so when we're thinking about the anatomy of a treatment effect, we know that there's a point estimate. So this estimates the treatment effect. And then this is surrounded by a 95% confidence interval, which the upper and lower bounds of the 95% confidence interval is the range between which we're 95% confident that the true treatment effect would lie. And so there's a handy relationship between the 95% confidence interval and the p-value in the fact that if this interval overlaps the point of no difference, there's no statistical significance between the treatment groups. The opposite also holds true. So if there's a big gap and the 95% confidence interval does not cross that point of no difference, it means that that result is statistically significant. This same logic can be applied to clinical significance in terms of, again, if it crosses that line of no difference, there's no difference between the treatment groups, but if it's further away from that point of no difference, then it'd be clinically important. So that now brings us to step 5, where we're going to review the 5 A's and identify ways that you can implement these skills into your everyday practice. For the last time, this session as well, just being mindful that hopefully you've got your evidence-based practice workbooks and you've taken some notes along the way. This is a resource for you to keep, and just make sure that you come back at a time when you encounter uncertainty or a problem in your clinical practice, as there's templates that can guide you and work you through the 5 steps that we've undertaken in this series to help you answer your clinical question using the best evidence possible. With that said, I'd now like to hand over to Chris Williams to take us through step 5, where we're going to assess the effectiveness of the first 4 steps and have a look at how to bring all of this together. Thanks, Chris.
Thanks, Zoe. Pleasure to be here today, and I'd just like to begin by congratulating everyone on making it this far through the training program, but also committing to the process. This is not new concepts, of course, but they are difficult concepts, and I can commend you all for embarking on this journey. So, yeah, we're talking about assessing the process as a whole, really, and the individual aspects of the 5 A's model today. So what that looks like is I'll just quickly recap on the 5 A model. Put some of those elements into my own terms, and then we're going to ask you to consider, from your point of view, your experience of using this model, and think about the sort of evidence-based practice influence that you might have, and ask you to set some intentions. So the original plan for this session was for it to be interactive. We don't have a group with us today, so what we'll do is ask you to consider some of these aspects, perhaps talk to some of your colleagues about them that may be embarking on this journey at the same time. And then I'll just quickly go through a case example of using this 5A model in a clinical setting. Okay, so the 5A's model, you would all obviously be familiar with asking, acquiring, appraising, applying, and today we're talking about assessing. All I want to do here is just touch on some things that I like to reflect on about our proficiency, or my proficiency in each of these domains or aspects of the evidence-based practice model. So when it comes to asking a question, one of the key requirements, I believe, is knowing really well what the problem is that we're facing. And so a point of reflection can be asking a question about how closely does that question approximate to the problem that you're dealing with. And this can set you up for success or failure, really, in the following steps of this 5A model. So if you haven't been able to get to the heart of a problem, often the question might not closely approximate the situation that you're dealing with. One of the strategies we'd learn about formulating a question was this PICO format, and this applies to studies of treatment effectiveness. So it's important to define aspects like the population we're dealing with, the type of intervention that we're considering, and of course the comparator that we're applying to it, but also the outcome or the impact that we're wanting to measure in terms of its success or failure. And then we move to acquiring. One of the things we can reflect on here was whether you're able to find an appropriate study for the question that you're interested in asking. And obviously, there are different studies for different questions. And so again, back to the example of treatment effectiveness. In this instance, we might be looking for trials of treatments, whether that be comparative effectiveness trials, randomized controlled trials, or other types of intervention designs. We might be interested in diagnostic accuracy, in which case we're looking for studies that are assessing the accuracy of our diagnostic tests, or perhaps we're interested in the clinical course or the prognosis of a a population that we're dealing with in the clinic, and we're looking at longitudinal cohort or observational studies. But this also applies to the level of evidence. So back to the intervention example, we've got randomized controlled trials, but then meta-analyses or systematic reviews of randomized controlled trials. So not only do we want to track down relevant evidence, the type of study that answers the question, but also the highest level of evidence that can answer the question. And then we might ask, in appraising this sort of evidence, things like, how much do I believe the answer? And then secondly, how useful is that answer to my clinical context? So when it comes to believability, we're interested in aspects of validity of the study, so how well it's conducted. That might be in terms of how well they've been able to follow patients for a period of time. So if there's lots of follow-up in a clinical trial, for example, the answer might be less believable. But also we're interested in the generalizability, so how well this applies, how well the answer applies to your clinical context. And that's about the types of people potentially that they include in the study. So moving on to applying this evidence, this fundamentally relates to how well you can integrate the evidence into your clinical decision making. And so you can be asking how well can you do that, and then what needs to change to integrate the evidence into practice. And today we're looking at how well we've been able to apply this process, and we can think about this in terms of your proficiency and skills in applying this model. This is obviously a nice framework to begin with, but there's other things that you consider. But also, we might be interested in what the overall impact of going through this model was on the clinical situation or perhaps patient outcomes. So now there's some time to reflect. And I might invite Zoe back into the conversation here. What we'd like you to do now is think about how you've been able to use the 5 A's over the last few weeks, perhaps how you've used it, where you've used it, and what worked well. Secondly, I want you to consider what the challenges were in using the A's model. It could be for each step along the way, or perhaps applying the model overall. And then I want you to come up with some ideas about overcoming these challenges. So, because we don't have an audience today, I'm going to ask Zoe to perhaps comment on some of the discussions that we've had in these sessions about where people are using this and what worked well, or perhaps some of the challenges that we commonly see.
I'm going to start with some of the challenges, I think, Chris. I think a lot of attendees had mentioned there were sort of two ends of the spectrum in terms of they hadn't yet had the opportunity to apply the 5 A's, but they were appreciative of the fact that there was a framework there from which gives them a bit of guidance to start. And so they appreciated that. But I think more people were more comfortable talking about some of the challenges to the 5 A's. And so in respect to asking the clinical question, it was often around really being able to ask a well-defined and answerable question. So identifying what key elements they required in that question. And I think in our research development roles, we do see a lot of people coming to us with quite long or complex questions. And when you're not sure of where to start with a project and you come with these types of questions, I think it's really evident to us that the issue is actually with the question, because again, it's not well defined and it's not actually answerable. There's too many ideas going on there. The project's actually bigger than Quo Vadis. And so it's around, I guess, trimming off or taking on some of those layers of complexity out of that question, and then really asking, okay, well, what's this? Who's the population? Who's this study going to impact, or who am I actually interested in? and then what's the outcomes I'm looking for, and really trying to refine that. Do you have any other experiences, Chris, with Ask?
I think that's a really important point. I mentioned starting with a problem, but certainly converting that problem into a question is a tricky task, and we don't often get it right the first go, and so it requires a bit of a iterative process, I believe, and yeah, iterative and reflective of whether that question is related to the problem that you're trying to solve. Yeah. One of the things that people often talk about in the acquiring aspect is the challenges finding the right type of evidence, but also navigating some of the systems that are required to acquire literature or academic papers. And a really important bit of insight was the fact that there are highly skilled people, i.e. librarians, available within the districts that can support this process. And so one really important point of reflection, I think, is to reach out to those skilled professionals, and they're actually really keen to help clinicians and health professionals with acquiring evidence. So yeah, reach out and make friends with librarians.
In terms of the appraising part of it, I think people are quite focused on the critical appraisal process, and we presented in the series that there's two ways to do it. You can do it the gold standard way using standardized checklists appropriate to the study design. Otherwise, you can use a more pragmatic approach and having a look at some of the key issues related to how the study's been conducted. Either way, we really encourage everyone, every time you pick up a paper, to spend a few minutes, target your reading, to try and do some sort of appraisal process and approach each paper you pick up with a bit of a critical eye, because we can't say it enough, just because it's published doesn't mean it's a good paper, nor does it mean that it's fit for your purpose. So it's really worth investing time in that critical phase and going, is this actually the best that I can find? Because it will save you time down the track. And something that I know I hear Chris say a lot about is around that research isn't always developed or written for clinicians. And so it's often not a failing of you in terms of your ability to understand the paper, but often it's a failing of the researchers and the people who write this research, that they haven't made a lot of the aspects clear and as transparent as they could have. So it's actually the issues are with the publications and the manuscripts themselves, as opposed to your limitations potentially in we reflect on ourselves, think it's our limitations in interpreting the evidence. So if you find this step challenging, we recommend that potentially reach out to your colleagues and reach out to others who might have research experience to help have that conversation. Reach out to your research office and say, look, can we have a go at going through this paper? Once you actually get the confidence to ask, there's actually a lot of people who are willing to help and help you along your way with your evidence-based practice journey.
That's a great point, Zoe, and I think that applies equally to the applying part of this cycle. So like with appraising, perhaps the bit of evidence that you're using isn't reported well, and so the application of it is really challenging. We know that interventions and treatments that are reported in clinical trials are not reported in a way that enables them to be used as intended in practice. So it's really important point to consider that there are failings of the evidence, and we need to overcome that somehow, and that's where clinical judgment, reaching out to other experts, can be really important. So we might move on. I should have said this to start with. In reality, there's no right or wrong way to do this. This is purely a framework to try and organise the process of evidence-based practice. And so how you apply this can be intuitive, it can be flexible, and you can sort of make up your own rules along the way. But these are just some points about perhaps trying to optimise this AIS model with some additional questions to reflect on. And I apologise if this is a little bit repetitive. We may have covered that in the conversation, but this is just create a bit more structure around those questions. So, obviously we want to ask if we constructed a specific and well formulated clinical question, but in particular, if there's some failing of that process or the question, then consider what are the elements that are missing, and that's when you can turn to things like the PICO formula. And then secondly, are you actually aware of what the best level of evidence is for different types of clinical questions? I mentioned treatment effectiveness previously, diagnostic accuracy, and prognostic studies. So upskilling yourself a little bit around what that type of evidence is, but also the best level of evidence for those particular types of studies. And then in terms of acquiring, we talked about this a little bit. How proficient are you with the relevant databases, and do you need help? There's certainly help out there, so reach out if you need it. The librarians are keen to engage with you all, and I'd encourage you to make use of their skills as much as possible. And then secondly, were you able to target perhaps the highest level of evidence in that search strategy? And if not, what has stopped you from acquiring the evidence, and what you can do about it? When we're going about appraising different types of evidence, you can use some targeted reading to make it a little bit more proficient. We learn about these concepts of validity or believability of the evidence, and you don't need to read the article in its entirety to pick out some of those aspects. And you can use some reporting frameworks or guidance frameworks to help you decide on the believability of a study. But touching on this issue again around poor reporting, you might not be able to decide on whether the study is believable or not based on how well those attributes of the study is reported. And then in terms of applying, you can be asking yourself, well, how well were you able to interpret the results in light of clinical importance, and in fact, was the study important to begin with? And then an important part of the application of evidence is how you can communicate those findings either to colleagues or to patients. So reflecting on and rehearsing your communication of a study's findings or the evidence that is emerging can be an important success factor. And then ongoing, I want to think about things like proactively monitoring improvements in the clinical setting, or practices in the clinical setting, but also improvements in emerging science in your field. And so this is unlikely to be just like a single process. It's much more of a cyclical process where we're looking for gradual improvements as evidence is emerging, and so that requires some for us to be proactive and monitor for evidence updates. So we'll move on again. This part of the session is about being strategic, and this is about fundamentally about intention setting, but also knowing what's motivating you to operate in an evidence-based practice way. So what we want you to do here, again, if a colleague's available, grab them, have a bit of a chat about this. We want you to ask, well, why is evidence-based practice important to yourself? It really gets to the heart of what you're trying to achieve in an evidence-based practice paradigm. And then think about how this works in your practice setting. So within the unit that you're working in, or the service that you're working in, consider how you might influence evidence-based practice and how it might be used routinely. So think about the support strategy you can apply. Does it need to be more strategic and considered, and perhaps the skills and training that you might be able to support some of your colleagues with. From there, I want you to move into one or two things that you're going to act on in the next couple of weeks. So write this down. what is the next step for either your evidence-based practice journey or education, or what you're going to do within your unit and practice. Okay, so now just to pull it all together, this is a couple of slides which aim to bring this whole process together, and I'll present a case study following this. This is a model that some colleagues and I have put together, which relate to both research and public health service actions in an evidence-based practice model. So on the right here, we have the need to identify a health problem. We've talked a lot about that today. And then moving into identifying solutions for this problem, we might look to systematic reviews. If systematic reviews or evidence is available, we might look to assessing whether that's being implemented or not. If so, we would monitor implementation. But if not, we might apply a similar process where we're looking for evidence about how to change practice. And so we can look to systematic reviews or other types of evidence to decide on the next steps and how to influence the use or the uptake of our intervention of interest. Often there may be evidence available to inform that sort of strategy, but there may not be evidence available to inform that strategy. And this is where we might enter things like quality improvement cycles to understand how best to influence the use or uptake of evidence-based practice strategies. So loosely put, this sort of this we can overlay the ask, acquire, or the 5A model in this framework, where steps 1 and 2 relate to asking, acquiring, and appraising. Well, it might be, for example, considering what interventions work, then what is the current practice, and then we're applying these principles into practice through a series of steps where we're asking what influences change. And we might be conducting a needs assessment of what needs to change or what are the issues in changing, and then understanding what strategies work best to change those. So just to finish off with a quick case study, this is an example that we conducted in an emergency department. And the clinical problem here was that there were a large number of patients presenting to ED with back pain. So these are non-urgent cases, and the challenges here were that the patients were receiving variable care, so really different types of care, some care not recommended by practice guidelines, but also there's challenges meeting service KPIs within the ED, so patients waiting for longer periods than perhaps necessary, a lot of patients being admitted, for example. And this problem was informed by a clinical perspective, so problems being identified by ED staff, but also audits of routine data showing that there's a high rate of opioid prescription, for example, or patients staying longer than New South Wales Health might like. So then we moved into a process of defining a question, or what best practice looks like. So we're asking, acquiring evidence, and appraising that evidence here. And so the question, the clinical question, so to speak, was around, well, what is the best practice for patients presenting to ED with low back pains? As it turns out, there are systematic reviews and clinical practice guidelines which inform what best care looks like. These include a number of randomised controlled trials and meta-analyses, and conclude that there's low to moderate certainty evidence of what to do in this practice situation. So the query here is, well, how do we influence this in the ED setting? So how do we apply gold standard recommendations for care for patients with low back pain? So what we did was conducted a needs assessment in the ED, and it involved consultation with ED clinicians about what the challenges, the barriers and potential levers we might be able to pull to influence recommended practices. What we did here is we used a framework called the TDF, the Theoretical Domains Framework, to define some of these challenges. And so we're considering things like the individual clinician characteristics, the characteristics of the treatments that we're asking them to introduce or perhaps not use. And then we're also interested in some of the settings determinants. So what are the influences within the ED that cause a clinician or a patient to, to want a certain type of treatment? But also the outside influences. So, for example, access to general practice or general practitioners or primary care, driving high presentation rates to the ED. And then, of course, we're considering the processes that are happening across systems that might be influencing high presentation rates or patients to prefer a certain treatment strategy. Then what we do is, considering all of those determinants, the challenges and the barriers, we look to map implementation strategies or practice change strategies to those particular barriers that can then influence changes or reduce the barriers, enabling better care. I'll show you what that looks like. So this is a diagram of the TDF domains that we looked at. So if the domains are down the left-hand side here, and I'll just pick out a couple. So in terms of knowledge, which is a within clinician characteristic, the black squares here indicate that they believe there's a bit of a deficit in how well they're able to assess and diagnose different attributes or different characteristics of back pain, a lack of knowledge around some of the recommended treatments. And from there, what we can do is then map those directly to evidence-based change strategies. So you can see how for knowledge or skills, we're looking at providing in-services or workshops, training, capacity building strategies to upskill those clinicians and improve their knowledge. But in contrast, if the issue was something like remembering what to do, problems with patient-centered decision making, then we might be looking at things like audit and feedback, performance reviews, or electronic decision supports, for example. So this just gives you an overview of the depth that you can go into in this sort of approach. But it's also important to assess the impact of how this went. So the way we did this was we conducted a mixed method assessment. So we did some qualitative interviews. We looked and we found that the clinicians were certainly, well, they had a lot more confidence in providing this type of conservative care. However, there were uncertain changes in the actual provision of care based on quantitative information, but there was a lower admission rate to inpatient hospitals. So there's some positives and negatives to consider. Ultimately, what that's meant is rethinking, how we go about improving or making change in the emergency setting. So over to you, Zoe.
Thanks so much, Chris, and thanks for a fantastic, first of all, overview of the 5 A's, but then taking it one step further in terms of having a look at how we then apply that to actually change clinical practice and inform our clinical practice based on best available evidence. So that's a great stepping stone into the implementation world. We're definitely drawing to the end of our session now. So the key messages from, I guess, overall from the 5 weeks that we've been together and from today's session is that evidence-based practice actually provides us with a framework to integrate current best evidence to make decisions. And If you recall way back to session 1, it's actually making our decisions more robust in the fact we're identifying and including best evidence from patients' perspectives and their family, your own skills as a clinician, and then research and combining this information to inform our decisions. Evidence-based practice is a skill that needs to be practiced, and you're not doing it alone. Just remember that there's lots of people who you can reach out to help. So there's the research office, there's librarians, and then also academics. So if you're unsure, please make contacts with those around you. Talk to your colleagues about the current issues that are most pressing and perhaps the ones that need to be addressed, and then get that team around you to help implement best evidence into practice. As Chris has guided us through today's session, it's really around taking the time to reflect on both your skills and abilities to undertake the 5 A's, but also reflecting on how you can become a champion for change and implement evidence into your everyday practice. Again, it's around identifying that team who can support you to ensure that you're an evidence-based practice professional, your team is implementing evidence-based practice, and ultimately this will improve patient outcomes. And making that commitment to a better tomorrow. So again, formulating that team and seeking help when required. We've been through that evidence-based practice journey together now. We can put a big tick next to session 5 in assess. And don't forget that you've got that workbook to keep as a resource to return back to at any time. So congratulations, you've completed this year's Introduction to Evidence-Based Practice seminar series. You should be very pleased with yourselves that you've stuck it through the 5 weeks, and we hope you've learnt something along the way. If you do, we have recorded all of the sessions as an enduring resource that you can return to at any time. There's actually all of the 13 sessions that's been delivered by the RR-CLaN in 2023. So please come back to these sessions and share them with your colleagues and work partners to just see how you can implement research into your everyday practice a bit easier. We're really appreciative of your time and attendance to these sessions, and we look forward to delivering you an action-packed education and training schedule in 2024. Thank you very much for attending, and all the best. See you next time.